but I think that you grossly you keep them uncovered, and then if you need
you're gonna have to cover both eyes. I
Right.
just demonstrated one, but yes, grossly you're gonna do without covering, and then when you're testing, you're gonna cover both eye individually.
Perfect. Okay. I'm
Any
hoping
other
that I'm
questions?
hoping that covers. Yep, she's got it. That's perfect.
All right, you're done. I'll call you if I need you again. All right, guys. So we're gonna move on. So the answer was A, B, C, D, E.
Right.
We getting the answers, Laura?
Yes, I'm getting a lot of A's.
Okay, beautiful. Yes.
Yep, all
right.
A's.
A is the answer. All right. Great participation, guys. I love it. See, we're nurses. We can improvise. Case number 3. 56-year-old Taiwanese female presented to the emergency room of your hospital with acute onset right upper lid ptosis. Okay? Noticed since 4 days ago. The patient reported that the right upper lid ptosis was with a progressive course, while no diurnal changes was noted. Okay. If you say that there are no changes throughout the day, that is very important. I want you guys to just note that she says that she has cystosis, but it doesn't change as the day goes by. Okay. Those are things that is a pertinent, very pertinent negative that you need to really take a hold of. The patient denied diplopia, meaning diplopia means that I don't see two things. Okay. If it's 2 fingers, I don't see 2 fingers, I don't see 2 people. Okay. She denies any blurred vision, denies any eye pain, denies any headache, denies any focal numbness or weakness. The patient also denies recent head trauma, prodromal symptoms suggestive of viral illness. Other medical problems includes diabetes, mellitus, type 2, without appropriate control, and diabetic nephropathy. Her usual medications before admission included short-acting insulin 3 times a day and long-acting insulin, but her compliance was poor. She never drinks or smoked. The brain CT performed in the emergency room showed no intracranial lesions. Now, how are you going to assess this patient? It's very important for you to do a complete neurological exam, but you have to do a really good history on her. Okay? What things give you ptosis? There are a lot of things that can give you ptosis. A lot of neurological issues can give you ptosis. A stroke can give you ptosis. What is ptosis, by the way? Okay? What is ptosis? Somebody turn on their mic and tell me what ptosis is. Come on, guys, not all at once.
An eyelid drooping?
Eyelid drooping, yes, it is. Which cranial nerve controls the eyelid? Which cranial nerve opens the eyes?
7. Oh no, 3.
3. Cranial nerve 7 closes the eye. Cranial nerve 3 opens the eye. So if I have a lid drooping, is that 7 or 3? Is that a deficit in 7 or 3?
In 3.
That is 3. Yes, because that means that they can't open the eye. That's why the eyelid is drooping. So if you have a ptosis, you know that there's something going on with cranial nerve 3. Now, important things you want to know: is there a brain tumor? Is there a stroke going on? Okay, but there are a lot of other things that can give you ptosis too. Okay, that you want to take note of. So you want to ask her, has she traveled outside of the country? Why is it important to know that? Because there are some viral illnesses that can give you issues that can give you a ptosis. Okay. What else do you want to ask? Why was it important to know that there was no change throughout the day? Why was that important?
Because it's not myasthenia gravis.
Well, it could not be done. It probably isn't myasthenia gravis, because
Okay.
myasthenia gravis,
Yes,
when you rest, it actually resolves. So they wake up bright in the morning, and then at night, as the day goes by, then their lid starts drooping as we progressively get further in the day. Okay. Diplopia. She has no vision issues. It's just this ptosis. Okay. So, is it an MS? Probably not. Is it a stroke? It's like, okay, well, it's a partial third nerve. And you'll hear neurologists say that a lot. Oh, they have a partial third nerve. That means it's only affecting some of the functions of the cranial nerve number 3. Okay, not all of them. Okay, let's see if she has anything else going on.
Dr. Morton, someone wanted to ask if we should do a tensilin test.
Well, you can do a tensilin test, and a tensilin test is actually to rule out myasthenia gravis. So if you want to just use that and say, well, you know what, this is probably not myasthenia gravis, then yes, you can do a tensilin test. And in most cases, they probably would do it just to say, well, you know what, this is not myasthenia gravis. A lot of times, though, neurologists are hesitant to do a tensilin test because what you're doing is you're giving this person, you're like giving their parasympathetic nervous system a boost when you give them this tensilon, okay? Because it is basically a cholinergic drug. So what could happen is you can stop that person's heart. That's why when they're doing a tensilon test, if you've ever seen it done at the bedside, you always have to have atropine there at the bedside, because if you slow that person's heart down tremendously, you have to give them the atropine to bring it back up. Remember, your cholinergic system says slow, your sympathetic nervous system says speed up. So if I'm going to give a cholinergic drug, I'm going to actually enhance the parasympathetic nervous system, and I'm going to enhance all the issues that the parasympathetic nervous system can do. So most neurologists, if they can help it, they won't do a tensilon test. They do it if they are like trying to rule it out really quick, if the person has no other medical issues. And they do it a lot of times more in the office setting, but they have to have them hook up to a 12 lead. They have to have atropine right there, and they have to be able to administer it if anything happens. Okay, it can become a code situation really quickly. So yes, you can do a tensilon test. Any other questions? What laboratory tests are pertinent for this patient?
Sorry, someone else had a question real quick. So it could be a palsy of nerve 3 brought on by a virus. Maybe she went home to Taiwan.
Could be. The viruses that come to mind are like herpes simplex virus, Lyme disease. Okay, so yes, it could be a virus. So you want to check, you want to do a viral load. You want to do like a Lyme titer. You want to do a herpes simplex titer. These are usually viral illnesses that can cause these. Okay. What other diagnostic tests should you obtain and why? What about an MRI? Would you do an MRI? I know you did a CT and your CT was negative. Remember, we just talked about CT is not being really good at looking at tissue. So would you do an MRI?
Yes. MRI might be indicated. Yes, to rule out.
Okay, beautiful. So what else can we do for this patient? I went a little far. What other diagnostic tests? Believe it or not, hemoglobin A1C.
Yes, of course, bro.
Is one of the most important things that you can do. It is very important for you to pick up on the fact that they're saying that she has diabetic nephropathy. One, she's diabetic with poor compliance. Okay. Diabetes mellitus is one of the most common things that give you a partial third nerve palsy, believe it or not. So for this lady, a hemoglobin A1C is paramount. And yes, this does resolve when she gets her diabetes under control. Any questions there, guys? So the things that can cause them.
Real quickly, someone said check the eye pressure.
Okay, why would the eye pressure, what would be the reasoning for checking the eye pressure? Did they answer?
Yes, glaucoma.
Okay, so glaucoma would not necessarily give you a third nerve palsy. Remember that the third cranial nerve sits in the bottom of the brain. It actually comes through where the almost where that sphenoid bone is at the bottom of the brain, and it travels through that area there through the the cavernous sinus. So anything that can press on those, the uncus of the temporal lobe that comes down can press on the third cranial nerve. You can get lesions along the third cranial nerve that can cause a ptosis. It can be affected like things like myasthenia gravis, diabetes. If there's trauma and there's bleeding into the brain, that can cause compression of the third cranial nerve and can give you that ptosis. A posterior communicating artery aneurysm, how it grows, can actually push on the third cranial nerve and give you a ptosis. Rupturing can give you a ptosis also. But glaucoma is, remember, it is essential. It's a problem in the eye. It's pressure in the eye. So it does not touch that third cranial nerve. Okay. Does that clear that up?
Yes, I think so. And then someone mentioned that head injury can be a cause, and I see it there on your list, trauma.
Yes, remember, bleeding into the brain, any trauma can cause compression of that third cranial nerve. You want to think third cranial nerve compression. Remember, we talked about where those cranial nerves are. We said that there are only two cranial nerves that are located in the cerebral hemisphere. That cranial nerve 1, which lays at the bottom of the brain, cranial nerve 2, which also is in the cerebral hemispheres. 3 and 4 are in the midbrain. 5, 6, 7, and 8 are in the pons. 9, 10, 11, and 12 are in the medulla. Okay, so you want to remember those. And so if you have an issue with the third cranial nerve, unless there's something compressing it or something along the myelin sheath that actually protects that cranial nerve, it should not disrupt the cranial nerve function. So if it's in the eye itself, the third cranial nerve does not run into the back of the eye. It actually innervates the eye, the pupil. So, I mean, if you knock out the complete eye, you can have some effects of the third cranial nerve, but remember, it just goes to the eye and innervates the eye. So, you have to have some kind of structural lesion compressing that third cranial nerve to give you a palsy in that respect. Okay? Any other questions, Laura?
I don't see anything. They're just saying, thanks for the clarification.
Okay, awesome. Case number 5, 65-year-old presented to the emergency room following a motor vehicle crash. She was seated in the rear seat of the car and was not wearing a seatbelt. During the accident, she sustained significant head trauma. In neurological examination, she opens her eyes to deep pain. Now, I need you to be documenting your GCS as I call these out. And then you're going to tell me what her GCS is. Okay? So she opens her eyes to deep pain. She is mumbling inappropriate words, and she moves her extremities to localize pain. What is her GCS?
Okay, 6,
No.
7,
10, 7,
No.
10,
10.
4,
10.
10, 10. Okay.
Yes. She opens her eyes to deep pain. That gives her a score of what, guys? Open to deep pain gives you a score of what?
Sorry, 2. They're answering 2.
Sorry, Laura.
No, it's okay.
The problem is if I open the chat, then I can't see the question. So that's why Dr. Abuha has to help me.
No worry, I thought all the 2s were coming, and I was like, no, the GCS isn't 2, but it was actually answering your question. So
No.
sorry.
She's mumbling inappropriate words. Is what?
3. I'm getting a lot of 3s.
Okay. And she is, what was the last part? She moves her extremities to localize pain.
5,
5.
Okay. So we counted, and she should be a GCS of 10. Correct? Okay. Yes.
Everyone's saying yes.
Okay. She intermittently holds her head up when she mumbles, and she's had 2 episodes of projectile vomiting since arriving to the emergency room. What is the significance of projectile vomiting, guys? Where's the vomit center?
Increase intracranial pressure.
Increase
Concussion,
intracranial
bleed.
pressure. Yes. But where's the vomit center in the brain? It's actually located in the medulla, which is in the brainstem. Okay? So if someone is projectile vomiting, you know that they have increased intracranial pressure and probably some brainstem herniation or brainstem dysfunction. Okay? She has some mild rhinorrhea. What is rhinorrhea? Anything with rhea at the end means CSF. So rhinorrhea, rhino, nose. Rhinorrhagia means that she's draining CSF and blood from her nose.
Yeah, they're all saying CSF from nose.
Yes. Rhinorrhagia is bleeding from nose, okay? Or she has no otorrhea, that means CSF from ear, but she does have some otorrhagia. That means CSF, that means blood coming out of the ear, okay? So remember anything with rhea, rhagia, rhea is CSF, rhagia is blood, okay? What is battle sign? Battle
Sign of basal skull fracture.
Okay. It is a sign of basal skull fracture. It is bruising behind the ear, though. I don't want to diagnose it. I want you to tell me where it is. Bruising behind the ear. What is raccoon's eyes? That is periorbital ecchymosis. Okay. You know, if you know what a raccoon looks like, you know they always have these dark rings around their eyes. Okay. Just not any seizures. She complained of double vision. Okay. And her field of gaze exam is below. I'm going to show you her field of gaze exam. What is that, guys? Which cranial nerve is being affected here?
3.
6,
Correct. Okay. Remember, the lateral rectus muscle pulls the eye out. If the lateral rectus muscle is affected and it's weak, the eyes are gonna set in. So the eyes are gonna settle in. So she has bilateral abducens palsy. She has both of her 6 nerves, cranial nerves, have a palsy in them. Okay, so both of her eyes are rotated in. So it's a bilateral 6 nerve palsy. If this was a bilateral 3rd nerve palsy, what would that look like?
it would be facing outwards.
Yes, they'd be pulled outwards. Okay. If this was a bilateral trochlear palsy, what would it look like? Dr. Abuha abandoned me.
Yeah, sorry, up and out.
Yes. Okay. I'm sorry, guys. Anytime I try to maneuver this thing, it moves. All right. So remember, cranial nerve 6 moves the eye lateral. Cranial nerve 3 moves the eye medial. It also moves the eye up and in. It also moves the eye down and out. It also moves the eye up and out. Cranial nerve 4 moves the eye down and in. Okay, forward to the floor. Okay, and cranial nerve 3 also moves the eye medially. So medially, up and in, up and out, down and out, 3. Laterally, 6. Down and in, 3. Down and in, 4. I'm sorry. Okay. Remember that the muscle that's affected is going to have less power. So what's going to happen is the eye is going to rotate to the stronger muscle. That's why both of her eyes are rotating in, because the lateral rectus muscle is dysfunctional. So the medial rectus muscle, which pulls the eye in, is actually taking over. That's why both of her eyes are pulled in. Okay? So what could be going on with this young lady? Okay? What could be going on with her?
I'm not getting anything.
Okay. It's not rocket science. Whatever has happened has actually compressed the 6th cranial nerve. Okay. We said where her Roscoe Como scale was, but whatever is going on is compressing her 6th cranial nerve. This was actually an actual case, and what had happened is basically she had a C1 C2 distraction injury that actually displaced her brainstem, and it caused a traction injury to the abducent nerves into the canal of dorsals. It's actually a canal at the base of the brain, close to the cavernous sinus, where the 6th cranial nerve comes through. Not that I expect you guys to know any of this, but that's just what had happened. It wasn't even an intracranial injury itself that caused this. It was actually a C1, C2 distraction that actually displaced the brainstem that actually caused this distraction of cranial nerve 6. Okay. And this happens a lot. You can see it. People come in with the bilateral abducens palsy, whiplash, increase intracranial pressure, hangman's fracture. They usually don't survive, but if they do, they can have it. Halo traction can give it too, because it actually can displace the 6th cranial nerve entry into this. Any questions or comments on that? This is not a test part, please, guys. I just need you to know what the 6th cranial nerve palsy is. I just wanted to let you know what the case was so you can have an idea. Any questions, Laura? Let me just look.
Just someone asked if this is going to be posted, and it's posted in all 3 sections.
Okay, guys. So a 47-year-old African-American man walked into the emergency department complaining of right-sided facial numbness and weakness. He said that it started before bed the previous night. The patient noted that fluid dripped out the right side of his mouth while he was drinking. Now, it concerns me that he waited until the next morning to come to the emergency room, but that's okay. That happens. He then awakened in the morning to right-sided facial droop, inability to close his right eye, excessive tearing from the right eye, and hypersensitivity to sound on the right ear. Okay, guys, from your assessment skills, which cranial nerve is being affected here? Laura, are we getting any answers?
Yeah, 6 and 2 are the answers I've gotten.
No way. Who said 6 and 2? No, guys.
7, 8,
unable
3,
to...
7, 7, 8. Getting a lot of different answers.
7. 8, no. I know you said 8 because of the hypersensitivity with sound, But remember that parts of cranial nerve 7 can actually innervate that sound. It actually, when damaged, can cause hypersensitivity to sound. And I actually think I have it on your PowerPoint. So just take a look at that. Okay. What else? It can actually control a little bit of the lacrimal ducts, so you see a little bit of excessive tearing. But this is all cranial nerve 7. Okay.
Some people are asking
All
Bell's
cranial nerve
palsy.
7. I'm sorry.
Some people are asking Bell's palsy ?
Okay. Why do you think it's Bell's palsy? Tell me. If you can put your mic on, that would be great. Somebody who wants to just put their mic on and tell me why they think Bell's palsy. Come on, guys. Shoot it out. Nobody? No takers?
I have a couple people that said flu-like symptoms, only upper part of his right side. He can't close his eye.
Okay. Well, his entire right face is affected. That's where your focus should be. I mean, he does not have just a lower part of his face. Now, if it was just the lower part of his face where he just had drooping of the lower part of his face, then that would probably be central. Okay, that's probably coming from the cerebral hemisphere. Now, if it's the entire right side of his face, then you want to think, okay, well, this sounds like it's peripheral, meaning that it's, remember, we have the central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, which are your spinal nerves and your cranial nerves. So this is something that is a peripheral issue. It's a cranial nerve issue, okay? So if you look at all the things that's going on here, there are right-sided facial numbness and weakness. He's dripping from the mouth, so the lower part of his face is affected. He has right-sided droop. He can't close his right eye. And usually if it's a stroke, they can close their eye. It's just the lower part of the face. So I want you to think, if the entire cranial nerve 7 is affected, it's probably peripheral, and that's when you're going to be thinking Bell's palsy. Now, not to say that you can't have a total cranial nerve 7 palsy with a stroke. It usually is a brainstem stroke, and those are rare. But if you see this, especially with the fact that this guy has had this over a few days, and the other symptoms associated with it, it's probably something like a peripheral issue, which will be a Bell's palsy. So on review of system, he's noted slight pain behind the eye. Usually strokes don't give you pain behind the eye, so that's usually it. He denies any recent cold sores, ear discharge, or recent trauma. However, he's noted to have flu-like symptoms. So definitely these flu-like symptoms are what's implicated and could possibly be the reason for your the 7th cranial nerve dysfunction. Okay. He has no previous medical history. However, he has not seen a doctor in 20 years. He denies any prior surgeries. He is a smoker, but denied alcohol or any illicit drug use. Okay. The point to this is I want to make sure that you understand the entire 7th cranial nerve is affected. It's usually peripheral. If it's the lower part of the face that's affected, it's usually central. So if I just have a droop of the face, and when I smile, I have a bend in the corner of my face, thinking at that point, when you look at that person, you're thinking central. This is probably coming from a stroke. Now, if they have a difficulty, they can't wrinkle their forehead, they can't close their eyes, they can't, they have tearing, they have the hypersensitivity to hearing. Sometimes they can have decreased taste on the back of their tongue. This cranial nerve 7 causes that. Excessive tearing, floaters, sometimes they can have that diplopia associated with it. Usually this is peripheral, meaning it is affecting the 7th cranial nerve. It's not something compressing it. It's not a dysfunction of that part of the brain, but it's usually something with the myelin, okay, that can actually cause this cranial nerve disruption. Any questions, guys?
I forgot to mention, someone had a question. What were the answers for case study, the cases number 1 and number 2?
I do not know, and I'm not going to go back there yet. Remember, guys, this is recorded. So it's being recorded, and you can actually go back. I'm going to post the recording as soon as it's available, and you can go back and look at those.
Okay, thanks.
Okay. On exam, the patient is in no acute distress, no obvious discomfort. He was hypertensive. On initial blood pressure is 182/108. His speech was slightly slurred, and that slurring of the speech is probably due to the facial weakness, not speech dysfunction. Okay, so this is not aphasia or any, this is a dysarthria, and that's a motor speech issue. Okay, so when it's dysarthria, is usually because of weakness that can cause the dysarthria. Okay. It also can be a cerebellar issue, but it's usually a motor issue. Okay. No nystagmus was noted. He demonstrated an inability to close his eyelid, as well as generalized weakness of his right face, including his forehead. His pupils are 3 millimeters, equal, round, and reactive, something that you guys like to call Perla, but you're not going to do that anymore after this class. You're going to say pupils are equal, round, and reactive. Okay. And his extraocular movements are intact. Now, his extraocular movements are cranial nerve 3, 4, and 6. And you want to move, the eyes should move smoothly through a letter H. I forgot to say that when we talked about the last case study. Your eyes should move smoothly together through the letter H or a star when you're looking at extraocular movements, okay? And in that case, you're going to tell the person to look at your finger, follow your finger with your eyes, do not move the head, and they're going to follow the finger through that letter H, okay? So you're going to go down, up, down, or you can tell them to follow it through the star, okay? And we already went through what cranial nerves are where, okay? Whichever technique is more comfortable for you, you can use that. So we already said which cranial nerve closes the eye. We said cranial nerve 7. Which cranial nerve is involved in facial weakness? We said cranial nerve 7. From the symptoms, does the symptoms appear to be peripheral or central? We said it was the entire 7th cranial nerve that was affected, so we think that it's more peripheral than central. And what diagnosis would you